So I am pleased to introduce our next speaker, Christine Ernon, who is an MS nurse for the University Hospital Liège, Belgium. And Christine will be talking to us about the challenges of MS nursing during the COVID-19 pandemic. So certainly a timely follow-up to the MEP's previous presentation. Christine has been a nurse since 1989, and she has been working in hospital nursing for 15 years. And then she became a nurse in the University Hospital of Liège. She comments that she is very lucky to work with a very passionate doctor who is working so very hard on behalf of people with multiple sclerosis and their caregivers. So she feels that she and her passionate doctor each are able to take time with patients and create a true relationship, which is such an important basis for MS care. She says that she has worked always in the same hospital during the years, and she has also worked as a teacher in the nursing school. So I would like to turn the presentation over to Christine.
Hello. I would first like to thank Pete Allen for his invitation and ask you to forgive my English. I don't speak English fluently. I left school a long time ago and I rarely practice orally. I'll first tell you about our experience with COVID. Our center is part of the Liège University Hospital, and our building is off-center and is intended for consultation. We follow around 600 MS patients with or without treatment. Among these patients, 40 were affected by COVID. 2 were hospitalized, not in intensive care units. And during the follow-up consultation, we observed among these 40 patients 2 who presented a clinical relapse and 5 who presented changes in the brain lesion in MRI. The first patient is a woman of 60 years old. Her BMI is 26. She does not smoke. Its EDSS is rated at 2.0. She has an history of ischemic heart disease. She was hospitalized for respiratory distress for 10 days in November. She is currently being treated with dimethyl fumarate after years of treatment with relief. Treatment was not interrupted during hospitalization. She suffers from a long COVID. She remains excessively tired and dyspnea at the slightest effort. The second hospitalized woman is 70 years old. She lives in a nursing homes and smokes a few cigarettes a day. Its EDSS is 6.5. Her BMI is also 26. She remained hospitalized for 5 weeks. Cognitive symptoms worsened. Her treatment with betaferon was interrupted during hospitalization and is not resumed. During the lockdown, most patients were anxious and wanted to stop their face-to-face work, even it was not dangerous, for example, working in a food store. We did not work much on phone or video consultations. The patients preferred to come to the hospital because there was no one else. All other consultations were suspended. There was no risk to come to our center. But most of patients cancelled blood tests and MRI scans even after the lockdown was over. They were still afraid to go to hospital or medical center. The vast majority of patients saw they were much more fragile than other people and needed reassurance. As soon as possible, we sent patients a folder from the French-speaking Multiple Sclerosis Society, written in French. It contained a lot of explanation on the pathophysiology and the precautions to be taken. Later, in November, we sent a letter from Professor Sandik from the Charcot Foundation about MS, virus, and COVID. Treatment were not suspended. Some patients were afraid because they thought that immunomodulatory or immunosuppressive treatments could increase the risk of severe infection. On this slide from Mrs. Sormani, we can see that it's not the treatments that are responsible for more severe infections. It is a combination of factors: age, EDSS score, comorbidities, and cortisone treatment in the months before infections. Steroids weaken patients. These factors are associated with a more severe form of COVID. For our patients treated with cladribine, some wanted to postpone the cycle by a few weeks as a precaution, and there has been no change in the management of patients treated with ocrelizumab or alemtuzumab. Some studies have shown that interferon and glatiramer acetate appear to protect against the severe form of COVID. I'm going to tell you about 2 cases of patients who presented a clinical relapse after suffering from the COVID infection. Mrs. G was born in 1966. Her diagnosis of multiple sclerosis dates from 2004. She presents brain and spinal cord injuries. She was treated with interferon, stopped for thrombocytopenia, then with Copaxone, stopped because of reactions at the injection sites. She is currently being treated with teriflunomide since October 17. She suffered from COVID in October 20. The first symptoms of fever and cough appeared on the 12th. On October 16th, she complained of ataxia and dizziness and paresis of upper right limb. We can see on the graph below the evolution of dexterity. Each point represents a consultation, and we can see that the time to perform the 9-hole peg test is clearly increased during the relapse, and walking speed is also impaired here. On the images of the cerebral resonance carried out on October 27th, we see the new lesion. There are circles in red. There was no contrast enhancement. The patient received 3 days of oral cortisone starting October 28. The recovery is very good, as can be seen in the following graph. During the consultation in January, the values of 9-hole peg test and walking test returned to normal. A new MRI was performed in April that shows a regression of the new lesions. Here is another clinical case, a 28-year-old young man treated with interferon since 2016. He had presented 2 relapses and was perfectly stable since the start of treatment. He presented with fever for a week in December 20. The antibodies were positive during the blood test in January. He presented new symptoms, mild and fluctuating diplopia with paresthesias in the left hemibody. He did not receive cortisone. On the resonance of the month of January, we see the new lesion circled in red and marked by the arrow. He accepted a change in treatment after the relapse and is now taking cladribine. Another case in a patient who did not have a clinical relapse following the COVID infection. She was born in 1974. Her MS dates from 2000, and she has been stable since 2002. She has been receiving first-line treatment since June 2002. Interferon, then Copaxone, and then currently teriflunomide. In April, she suffered from fever and dyspnea, severe flu condition. COVID antibodies remained negative. On the control resonance in February, we can see the appearance of 5 new flare lesions with no contrast enhancement. Some patients with benign multiple sclerosis do not receive treatment. In some of these patients, the appearance of new lesions after COVID did not justify the initiation of treatment until now, but radiological follow-up will be closer than before. Vaccination is highly recommended, regardless of the vaccine offered. A few studies show that the humoral response is somewhat poorer in patients treated with anti-CD20 or fingolimod. A third injection may be considered in some patients, depending on the country where they are living. We see here the result of the vaccination. Compare with unvaccinated controls. 5 days after the first dose, 46 less infection, and 1 week after the second dose, 92. Severe infections were reduced by 92%, and there were no more deaths linked to COVID as early as the week following the second dose of vaccine. And so we try to convince all patients to get vaccinated. Professor Deve's patients have absolute confidence and always want his consent before agreeing to vaccination or other treatment. And to conclude, here is Dr. Deve's message regarding the COVID vaccinations. As quickly as possible in as many people as possible. Voilà.
Well, thank you, Christine, for your very nice presentation and your very good English. I had no difficulty to understand you. We invite the audience to put their questions in the chat box, and as we wait for some questions to come in from the audience, I do have a question for you, and that is about the third possibility of the third vaccine. Have you administered a third vaccine to any of your patients with the anti-CD20s or fingolimod?
Yes, a vaccination is recommended, and all patients who agree received the vaccination. But there is last week an article in in the media from Dr. Pelletier, and this has been followed by many stress for patients because this paper explained that the vaccine with Ocrevus of anti-CD20 treatment does not work. So patients are afraid. It's normal. It's not a good publicity for the vaccine. It's a big. Sorry, my English is not fluently. I'm sorry. This paper is bad for the patient treated with fagolimot or Ocrevus because it's not a good answer. Antibodies are minder, but they are not only antibody to test to evaluate the efficacy of the vaccination. It's not the only way. So we try to convince to be vaccinated, even the treatment with Ocrevus. I'm not sure to have answered to your question.
Yes, you have answered my question quite well, and I have a comment, and that is that I know that there are ongoing studies now looking at T-cell responses and the fact that perhaps it is actually the T cells that are helping to produce some of the antibodies in people who are on these B cell depleting therapies. Because there has been some evidence that people, despite being on the anti-CD20s, are actually mounting a response to these COVID vaccines. And the thought is that perhaps it's coming from the T cell activity. Charles would like to respond to Dr. Pelletier's paper. So if we can bring Charles on.
Yes, thank you very much, Amy. And thank you for my compatriot's excellent presentation. Your English indeed is perfect. I would like to make a short comment because we submitted in Belgium to our medical advisory board Mr. Pelletier's statement, which was spread a bit too early. And our medical advisory board has been stating very clearly that it is totally premature because the studies to sustain what he is suggesting, without criticizing the professor, obviously, but that the statement was totally premature because the result of the studies will only be available at earliest 6 months. And even then, we should not be speculating. I think it has adverse effects on persons with MS, and it could cause panic, which is not justified. So our medical advisory board was quite clear on that. Thank you.
Thank you, Charles. Yes, the discussions with the neurologist in my practice are also in agreement that the statement was premature. And as Christine has said, it's frightening to the patients because they feel that they don't have hope or they don't have an option. Despite that, in our practice, we encourage all of our patients to become fully vaccinated. And as I said, we tell them that there may be other ways, such as through their T cell activity, to actually mount a response. Again, it may not prevent a COVID infection, but it certainly So far, preliminarily, in early evidence shows that we're not seeing the severe cases that have required hospitalization. And I appreciate your comments about your patient, Christine, who has the long COVID. Can you tell us a little more about what some of the symptoms are that that patient is experiencing as a result of long COVID?
Yes, we have 2 persons with long COVID. They are still very tired, and they are afraid not to be to become just before the infection. They have no energy, and they are a little depressed because they feel so tired at every activity. They need to rest, and they were usually for dynamic persons. But about MS, now they are recovered the first state, the initial state. I'm going
That's
to go
helpful.
school to learn English again.
No, you're doing very well. Your
Oh,
English is much better than my French, believe me. So, your comments about the fatigue for your patients, I find that is something that we see in our long COVID patients as well. We have in our university hospital in Chicago, in the US, have established a long COVID clinic where we are seeing many patients with neurological complications of COVID, and fatigue is one of them. I find one of the challenges when we are looking at people with MS is to try to distinguish how much of the fatigue is related to their MS, how much fatigue perhaps they have before COVID, and how much is really related to COVID. We do our best to, in our long COVID clinic, involve our partners in physiotherapy and rehabilitation. Because as you said, people find that they are incredibly fatigued doing simple activities, such as standing to wash the dishes or preparing a meal, for example. So our rehabilitation colleagues have been very, very helpful to us in identifying ways to manage some of these tasks so that the patients can conserve as much energy as possible. And that's one of the things that we are trying to do for our people with MS. We also find, as you do, that our long COVID patients are experiencing significant depression and anxiety because, again, they're feeling that, well, I have the COVID. I don't know that it's useful for me to take the vaccine now. And our response is there are studies ongoing with preliminary reports that people who suffer long COVID, who go on to actually have the vaccine, begin to feel better. About 40% of them begin to feel an improvement of those long COVID symptoms after the first COVID shot or injection, and about 45% actually report an improvement in their long COVID symptoms when they are fully vaccinated after their second injection. So that is one of the things that we talk to our patients about to try to provide them some hope. We have a question from the audience, Christine from Stefan de Court, who is asking, how did you keep the communication going with your people with MS?
Please, can you repeat the question?
Yes. How did you keep the communication going with your people with MS?
I don't understand what you mean. I'm sorry.
That's okay. How during COVID, how did
Yes,
you communicate? Did
communicate
you Yes.
by phone and mail. By phone and by mail. I was present in my office every day, like usual. So I could answer the question by mail or by phone, and people knew that we were available. So they don't hesitate to phone or send a mail. Yes.
Great. In our practice, we were able to do some video visits. Most of our practice was all live because, like you, people felt safe coming to the university, to the clinics. The number of people was down. Many of our patients were feeling very isolated at home and felt like they wanted to come in to communicate with the staff, to actually interact live with people who could help them or assist them, and to some of them who were unable to come in, we were able to do the video visits. It's difficult, as you imagine, to assess a person over a video, but one of the things that I have found is asking their carers, their family members or carers, to assist us. So if we are looking at their walking or trying to look at how they're using their hands, for example, we ask the carers to hand them things or to assist them with walking and follow their walking with the camera phone. So we've strongly encouraged our carers to be able to be participating in those video visits. Another question is, are there statistics on how many MS patients experienced a relapse when they had COVID?
In our center, clinical relapse, only 2, and MRI relapse, there were 5 persons. And we learned a few days that a 6th woman presents new lesion in MRI, in brain MRI, after COVID. But we have not received her in consultation since the COVID. So it's it's a MS rehabilitation center that said us that there were new lesions. So it's 6 persons not yet examined in consultation.
Thank you for that. I know that there are several registries, national registries as well as international, that are looking at COVID in MS. One large one in Italy. There is a large one that is spearheaded in North America called COVID-MS, COVIMS. And I can tell you, I don't know the actual statistics, but surprisingly to me, the number of clinical relapses is low. It's lower than I would have anticipated, but I think it is very similar to your experience in your university hospital. If we think they are experiencing a relapse, we of course will order an MRI. and confirm that relapse with new lesions or dispute that new relapse as a pseudo relapse or just a worsening of symptoms. So I would like to remind everyone that there will be a session on the COVID-19 vaccines that Professor Dr. Hans-Peter Hartung will be presenting on Friday at 10 a.m. So I would encourage everyone with vaccine interest and questions to participate in Professor Dr. Hans-Peter Hartug's session on Friday at 10 a.m. I would like to thank Christine again so much for not only your excellent presentation, but your ability to respond to questions in English, and you have done so well. You've provided us with a lot of good information. Thank you so much. At this point, I would like to ask our Andres to please post the drawing for the session this morning. Wonderful. Andres, you are
Thank
a
you.
master. Thank you so much.
Thank you.
At this point,
Have a
I would
nice
like
day.
to say thank you all so much for attending this session. We will now be taking a coffee break from now until 11:45, and we will ask you to return promptly at 11:45 for our next session. But during the coffee break, we invite you not only to have a coffee or a tea, but also to spend time with the meet and greet session, as well as viewing some of the exhibitions and the posters that are available on the platform. Thank you.